Hello! In this video we're going to look at the pathophysiology of movement disorders, but first of all we're going to take a look at the normal anatomy and physiology of the basal ganglia and cerebellum. So let's start off by taking a look at the basal ganglia. Now, the term basal ganglia is troublesome for a number of reasons. The first is one relating to the nomenclature, because the term ganglion or ganglia, as you should appreciate from videos I've made before, relates to a collection of cell bodies in the peripheral nervous system. However, the basal ganglia are very much central nervous system structures. And this is simply an historic vestige whereby a very old-fashioned term has remained in common parlance and no one has really changed it at all. So we are stuck with the term basal ganglia, even though ganglia is a relatively poor term. The second important point about the basal ganglia is that this is a collective term referring to a whole load of rather disparate structures. They don't all have common developmental origins, they all have quite different functions, and they're related to each other in a variety of ways. So this is a catch-all term, essentially relating to the components of a circuit which is important for the analysis of motor plans produced by the primary motor cortex. So the key components of the basal ganglia, well, the first is most easy to recognise in a coronal section through the brain. If you look at a coronal section of the brain, you will typically see sitting quite close to the midline, sitting just beneath the lateral ventricles, the thalamus. Then, going a little more laterally, you will see the internal capsule, which is, as you should know, the major motor pathway running down through the deep part of the hemisphere. And then sitting superficial to this is a triangular structure which is called the lentiform nucleus. So this whole triangular structure here is the lentiform nucleus. And the lentiform nucleus is composed of two major portions, and one of those portions is further subdivided. The superficialmost portion is the putamen, and the putamen and the neighbouring caudate nucleus are very closely related. And if we wish to see that relationship between them, we should look at this image on the bottom right-hand side. Here, the cerebral cortex has been dissected away to reveal the basal ganglia from the lateral aspect, and this is the putamen just here. And we can see that the putamen in red is actually connected by these grey matter bridges to the C-shaped caudate nucleus. So this is the caudate nucleus and it is C-shaped, and in fact the putamen and the caudate are both derived from the same ancestral nucleus, and we could call them both together the striatum. So the striatum is the combination of the putamen and the caudate nucleus. Now they got separated when the corticospinal pathway evolved, and as those corticospinal axons descended down, forming the internal capsule, they punctured holes through the striatum, separating it into caudate and putamen. So caudate plus putamen makes up the so-called striatum. However, this lentiform nucleus is made up of the putamen sitting laterally plus the globus pallidus, which sits more medially. And the globus pallidus is composed of an external segment here and an internal segment here, the so-called globus pallidus external and globus pallidus interna. Now, effectively, the striatum receives input and the globus pallidus sends output. Okay, so the striatum receives input from the cortex and the globus pallidus sends its output back to the cortex via the thalamus. That is the coarse segregation of function between those two components of the lentiform nucleus. Now we do have additional components as well to consider, and the other major additional component is the substantia nigra, which is in fact a part of the midbrain. So the substantia nigra sits just deep to the cerebral peduncles, which are just here, and the substantia nigra contains dopaminergic neurons who send their axons up to the striatum in the so-called nigrostriatal pathway that runs in this approximate trajectory here. So this is the nigrostriatal pathway that goes from the substantia nigra up to the putamen and the caudate. So these are the most fundamental parts of the basal ganglia. The lentiform nucleus being an anatomically defined structure, whilst the striatum actually being a functionally and evolutionarily defined structure, since the putamen and the globus pallidus contain very similar neurons. Now on the top right hand side, what I'm showing you here is in fact what's called a DAT scan, and this is a scan showing the levels of dopamine within the brain. And essentially, if you see a lot of this red colour, reddy blue colour, this suggests there's a lot of dopamine present, whereas if you see more greens, this suggests that there is less dopamine present. And here we're looking at the striatum, particularly the putamen, and we can see in the control there's a lot of red signal just here, whilst in a patient with Parkinson's disease who has less dopamine in their brain coming from the substantia nigra, then that red signal is far lower. So this just goes to show how we can do a specialized scan picking up dopamine specifically, which can highlight the shape of the putamen in a transverse section. So that's the very basics related to the anatomy of the basal ganglia. And now let's just look at the very basic anatomy of the cerebellum. Now the cerebellum sits in the posterior cranial fossa, and we can see it very nicely on this sagittal section just here. It sits dorsal to the brainstem, particularly the pons, and you can see that the cerebellum itself forms the roof of the fourth ventricle just there. And it also sits inferior to the occipital lobes and is separated from the occipital lobes by the tentorium cerebelli. So the cerebellum sits very, very snugly in the posterior cranial fossa. If you take out the cerebellum and look at it, you note that it has three major components: two laterally placed cerebellar hemispheres and a midline cerebellar vermis. And in fact, the somatotopy of the cerebellum, that is the way in which the cerebellum maps onto the body itself, it is important to realise that the vermis deals with the midline, whilst the cerebellar hemispheres deal with the more distal structures. The cerebellum is connected to the brainstem by three separate white matter pathways, the so-called cerebellar peduncles. And we can see the cerebellar peduncles here. Okay, so this is the cut face of the cerebellar peduncles. We have the superior cerebellar peduncle connecting the hemisphere to the midbrain. We have the middle cerebellar peduncle connecting the cerebellar hemisphere to the pons, and the inferior cerebellar peduncle connecting the cerebellar hemisphere to the medulla. So in order of superior to inferior, the superior, middle and inferior peduncles connect to the brainstem. You note that the largest of the cerebellar peduncles is the middle cerebellar peduncle, and that is because a huge amount of inputs get to the cerebellum from the motor cortex via the cortico-pontocerebellar pathway, and that passes through the middle peduncle at the level of the pons. Now, I don't expect you to know a great deal of detail about what the fine circuitry is within the cerebellar hemispheres, but if you do any reading on this, you will discover that it is incredibly beautiful. The cerebellum has a remarkably ordered ultrastructure, and this is telling us something about its function. We don't quite know what it's telling us, but it must be telling us something, because we know how structure and function are so closely related. So I don't expect you to know a great deal of detail about the circuitry within the cerebellum. However, it is more important that you appreciate the way that the cerebellum connects with other parts of the CNS. So that's the anatomy of the cerebellum at its most basic level. Now, both cerebellum and basal ganglia communicate with the motor cortex via these looping circuits. So there are looping circuits going from cortex to basal ganglia and then back up to the cortex, and also looping circuits going from cortex to cerebellum and then back up to the cortex. And the reason that we have these loops is that the basal ganglia and the cerebellum are involved in the analysis of motor programs, if you like, produced by the primary motor cortex. The key role that the basal ganglia have is in determining what the most appropriate set of movements should be in order for us to carry out some kind of task. And the example I always use is picking up a drink. And in the case of the basal ganglia are going to ensure that when you pick up a drink, you flex your fingers, you flex your elbow, you flex your shoulder to get that drink up to your mouth. It's going to make sure that you don't extend at any point, because that would not facilitate you bringing the drink to your mouth. So in a nutshell, the basal ganglia are very important in selecting the most appropriate movements to carry out a task. Whilst the cerebellum, what that is involved with is in determining the most appropriate sequence of movements which are going to enable you to carry out your task of interest. So once again, in the case of picking up your drink, you would not, for example, flex the shoulder first before you had flexed your fingers around the cup. So therefore, the cerebellum is going to make sure that you first flex your fingers, then you flex your elbow, then you flex your shoulder. It's going to make sure that the appropriate sequence is carried out. So that is in a nutshell, what the basal ganglia and the cerebellum are trying to do. Staying with the basal ganglia, we also need to recall that the basal ganglia have an input from the substantia nigra, and this is a dopaminergic input. And in the case of the basal ganglia, what dopamine is doing is acting as a kick starter, if you like, giving the motor cortex a real hit of stimulation to get the body moving. And we're going to look at that in more detail soon. So let's focus now upon the basal ganglia. And basal ganglia can be quite daunting when you first look at diagrams of the pathways. And in your exams, I want to reassure you that I don't expect you to memorize the basal ganglia pathways. What I do expect, however, is that you would be able to look at a diagram like this and interpret it. Okay? So you need to understand what is going on when you're looking at a diagram like this. So what we're going to do is, first of all, consider the normal function of the basal ganglia. And so we're going to look at the so-called direct and the indirect pathways, and consider how they contribute to the way in which the basal ganglia can analyse a motor plan produced by the motor cortex, facilitate appropriate movements, and edit out inappropriate movements. So when we are considering the normal function of the basal ganglia, it helps to start off at the level of the striatum, and we're focusing on the putamen just here. Now, the putamen here communicates with the internal segment of the globus pallidus, and this is the first portion of the so-called direct pathway from putamen back up to cortex. And what you must note is that the neurons projecting from the putamen to the internal segment of the globus pallidus are black in this diagram, meaning that they are inhibitory. So let's just emphasize that and just show that these projections here are inhibitory. So the putamen inhibits the globus pallidus. But look, the globus pallidus inhibits the thalamus, okay? So the globus pallidus is itself inhibitory on the thalamus, whilst the thalamus normally excites the cortex, and we've established that in many previous lectures. So in the direct pathway, what we have is inhibition of an already inhibitory pathway. And in order for us to appreciate what the effect of that is, we can just go back to the very basic arithmetic dealing with positive and negative numbers. Remember that if you multiply a negative number by a negative number, you get a positive number. And that is exactly the same case with inhibition of inhibition. If you inhibit this inhibitory influence, you decrease the amount of inhibition on the thalamus, and this leads to a net increase in the activity of the motor cortex. And this fits with what we know about the direct pathway. We know that the direct pathway is that pathway which is involved in the facilitation of appropriate movements. So if we wish to facilitate appropriate movements, it makes sense that we use a pathway which is net excitatory to the motor cortex. And that is indeed the case here. So the direct pathway is net excitatory to the motor cortex. So now let's think about the indirect pathway. The indirect pathway is a little more complex. The first component that we see is that the putamen sends inhibitory neurons down to the external segment of the globus pallidus. So the putamen inhibits the external segment of the globus pallidus. In turn, however, the globus pallidus is inhibitory on the subthalamic nucleus. Okay? So at this point already, we see that we have inhibition of inhibition. So this indirect pathway, what we have is that we have net stimulation of the internal segment of the globus pallidus via the subthalamic nucleus. Let me reiterate how that comes about. The putamen inhibits the external segment of the globus pallidus, which is normally inhibitory on the subthalamic nucleus. So if you inhibit this inhibition, it means that in fact the activity of the subthalamic nucleus is increased, meaning that it stimulates the internal segment of the globus pallidus. By stimulating the internal segment of the globus pallidus, this then inhibits the thalamus even more. So the indirect pathway is inhibitory on the thalamus and inhibitory on the motor cortex. And the consequence of that is that the indirect pathway can inhibit the motor cortex and hence inhibit inappropriate movements. So the net effect is that the direct pathway is excitatory via inhibition of inhibition, whilst the indirect pathway is inhibitory via initially inhibition of the subthalamic nucleus, which results in stimulation of the GPI and subsequent inhibition of the thalamus. Now, don't expect that you're going to get this immediately. This takes a long time for you to fully get your head around, but be reassured that you will always be given the diagram to refer to, and the most important skill I want you to develop is interpreting what is going on. So that is how we can think about the normal function of the basal ganglia by starting at the putamen and working our way down through the direct and the indirect pathways. However, if we are to understand pathological conditions such as Parkinson's disease, it makes sense to actually start our journey at the substantia nigra, because it is here that we get degeneration of dopaminergic neurons. Now, we need to appreciate something additional first, and that is that dopamine has two different effects on the putamen depending upon which neurons the substantia nigra is projecting onto. There are two populations of neurons in the putamen. One population harbours D1 receptors, dopamine D1 receptors, and they are stimulated by dopamine coming from substantia nigra. And the second population of putamen neurons harbours D2 receptors, and these are inhibited by dopamine coming from the substantia nigra. So let's see what effect this has. So starting with dopamine and making our way through the direct pathway to the cortex, we note that dopamine through the D1 receptors is stimulatory to the direct pathway. If we stimulate the direct pathway, we increase the level of inhibition on the internal segment of the globus pallidus, meaning that we decrease its inhibition of the thalamus, meaning that thalamic activity increases and cortical activity increases. So starting at dopamine, the direct pathway is facilitated by dopamine and cortical activity increases. Now let's look at the indirect pathway. Remember, we said that the indirect pathway is net inhibitory on the cortex, isn't it? In the normal situation, the indirect pathway is net inhibitory on the motor cortex. However, if you inhibit this inhibitory pathway via these D2 receptors, then you actually will increase the level of activity in the cortex. You take the brakes off, don't you? You inhibit the inhibitory indirect pathway. So regardless of whether dopamine acts through the direct pathway or the indirect pathway, dopamine will serve to stimulate the motor cortex. And that is why I like to think of dopamine as like a kick-starter on the motor cortex, because regardless of which pathway is involved, dopamine will stimulate activity in the cortex itself. Now, once again, you're going to have to go away and think hard about this. And you've also got to realise that it's not a constant stream of activity going into each of these two arms of the pathway. There is a dynamic balance here, and the amount of dopamine being sent to the direct pathway versus the indirect pathway will change depending upon how the basal ganglia circuit processes the motor plan coming from the cortex. But that is really at a much higher level than I want you to be working at. I want you simply to be able to explain the normal function of the direct and indirect pathways and what the effect of taking dopamine away would be. And we're going to look at that in more detail soon, but in a nutshell, if we said that the action of dopamine is to stimulate the cortex via both of these pathways, if you take dopamine away, you're going to decrease cortical activity, and that is the essential cause of the symptoms of Parkinson's disease. So what I've done here is I've taken that pathway and I've added on some lesions. So let's start off with Parkinson's disease. So we're going to look at Parkinson's disease, which is caused by the degeneration of dopaminergic neurons present within the substantia nigra. As we said, if we take away dopamine provided by the substantia nigra, then we lose that net excitation on the cortex, because we said that dopamine stimulates the direct pathway, which is normally excitatory, and it inhibits the indirect pathway, which is normally inhibitory on the cortex. So with the loss of dopamine, the result is that cortical activity will decrease. And the decrease in cortical activity to a large extent explains some of the features of Parkinson's disease. The most obvious one that it explains is the bradykinesia that we see in Parkinson's disease. Bradykinesia relates to slowness of movement, and this is caused by decreased cortical activity, meaning that the corticospinal pathways just aren't stimulating lower motor neurons adequately. So this model here is best at explaining the presence of bradykinesia. Rigidity is more difficult to explain and cannot be explained by this simple model. So don't try to explain it using the simple model. You've got to appreciate that in normal physiology and in the pathological cases, the action of the basal ganglia is essentially a dynamic thing. So there's constant activity buzzing around this circuit and through the cortex and the thalamus. And it's not going to be explicable just by a simple diagram like what we've drawn. So we know pretty well how bradykinesia arises, but the rest of these are harder to work out what's going on. But I can try and help you by doing a little bit of speculation. The rigidity may be caused by the fact that we are no longer coordinating the action of agonist and antagonist muscles. Remember that in previous lectures we've said that the direct pathway and the indirect pathway are working to edit the motor plan, so to speak. And we said that in order to pick up that drink, you had to use flexors but inhibit extensors. And if you are not properly coordinating flexors and extensors, not making sure that they're switched on and off at appropriate times, maybe that causes the rigidity in the limbs. The tremor is far more difficult to explain, and it is likely that in the pathological circuit there is reverberatory activity which is going on unregulated that could lead to the tremor, but that is speculation. Psychiatric features are prominent, particularly in the late stages of Parkinson's disease. And the interesting thing to consider here, as you will encounter when you do the psychiatry part of the clinical neuroscience unit, is that not only are loops like this involved in the motor system, but they are also involved in the cognitive and emotional systems as well. So the frontal lobe, the temporal lobe, which are involved in cognition and emotion, also participate in looping circuits with the basal ganglia. And this probably helps to explain why we see psychiatric features in many of these conditions where we have degeneration in the basal ganglia nuclei. Another movement disorder that you need to appreciate is Huntington's chorea. Now, Parkinson's disease is typified by decreased movement. It is hypokinetic, whilst Huntington's chorea is typified by increased movement. It is hyperkinetic. And it is believed that the primary problem in Huntington's is degeneration of inhibitory influences running from the putamen to the external segment of the globus pallidus. And let's work through what's going on here. If we have lost inhibition of the external segment of globus pallidus, that means that the GPE activity will increase. Okay, let's just put a little arrow there. If we lose these inhibitory influences on the GPE, its activity will in turn increase. This means that it will be inhibiting the subthalamic nucleus more, meaning that the subthalamic nucleus's activity will decrease. If the subthalamic nucleus activity drops, it means it's not stimulating the internal segment of the globus pallidus as much, meaning that this structure is not inhibiting the thalamus adequately, meaning that thalamic activity increases, cortical activity increases, and hence movement increases. So Huntington's chorea is a hyperkinetic disorder caused by loss of inhibition of the external segment of the globus pallidus. So we have these choreiform movements, these involuntary movements, and we also have problems with coordination and psychiatric features once more in this condition. So Huntington's is a hyperkinetic movement disorder. Another hyperkinetic movement disorder is hemiballismus. Okay, whoops, I just meant to use the eraser there. Is hemiballismus. Hemiballismus is typified by explosive unilateral movements. So involuntary explosive movements on just the one side. Hence the hemi for half and ballismus referring to ballistic movements. And hemiballismus is caused by lesions to the subthalamic nucleus. Now let's think about what damage to the subthalamic nucleus does. If we damage or destroy the subthalamic nucleus, we are no longer stimulating the internal segment of the globus pallidus adequately. If the activity of the internal segment of the globus pallidus drops, it means it's not inhibiting the thalamus as much, meaning that the activity of the cortex will increase. So damage to the subthalamic nucleus will lead to increased cortical activity. So for your exams, essentially there's only so many exam questions I can write about the basal ganglia circuit. And really what you need to be able to do is to take any portion of this, okay, accepting the PPN and the SNR. As I said in the previous slide, you can ignore those. But what you should be able to do is take any portion of this pathway and predict what the effect of damage to it would be, or alternatively, what the effect of stimulation of that structure would be. Because what we can do, for example, in the case of Parkinson's disease to treat it, is we may wish to electrically stimulate the substantia nigra. And as we know, if we electrically stimulate the substantia nigra, maybe we'll release more dopamine into the striatum, maybe stimulating the cortex more. So there are only so many permutations that you can go through before you've covered the lot, but you need to be able to predict the effect of damage or of electrical stimulation to any portion of this pathway, with the exception of SNR and PPN. So that's the basal ganglia disorders, and let's finish off by just considering cerebellar lesions. Now, the classic symptoms of cerebellar damage, symptoms and signs of cerebellar damage, can be remembered with the mnemonic Danish, okay? And that this list of signs, along with the fact that the cerebellum leads to ipsilateral effects, is the cerebellum in a nutshell as far as you're concerned. Damage to the cerebellum typically presents in patients with vomiting. They might experience vertigo, and they might well experience difficulty walking due to problems with incoordination of the lower limbs. As I alluded to earlier, the cerebellum has a somatotopic organisation where the midline vermis of the cerebellum deals with the trunk, whilst the more laterally placed hemispheres deal with the limbs. So if you see a patient with truncal ataxia, problems with coordination of the muscles of the trunk, you can localise to the vermis, whilst if you see a patient with cerebellar signs in the more distal parts of their upper or lower limbs, you can localise to the hemispheres. Quickly to go through these features, dysdiadochokinesis refers to a deficit in rapid alternating movements, and you should have seen this as asking a patient to pronate and supinate rapidly. Ataxia relates to their gait, so cerebellar ataxia, that they have trouble walking, trouble keeping upright, maintaining their equilibrium, typically a wide-based gait. Nystagmus is a flickering movement of the eyes, an involuntary flickering movement of the eyes, and in the case of nystagmus caused by cerebellar lesions, the fast phase of the nystagmus is towards the side of the lesion. And you can remember that as fast towards. So fast, the T in fast reminds us that it is towards the side of the lesion. Intention tremor relates to, as a patient when doing the finger-nose test gets closer and closer to your finger, their tremor worsens, okay? As opposed to in Parkinson's, where if you ask a patient to do something, it tends to ameliorate the tremor. Dysarthria is caused by problems with coordination of the muscles of the larynx and pharynx, just like how any other muscle might be affected. And hypotonia in the limbs is a feature of cerebellar lesions, but we're not entirely certain why that would occur. Finally, remember that the blood supply to the cerebellum is from the vertebrobasilar system, and that the three cerebellar arteries, occlusion of them does tend to cause similar symptomatology. However, don't forget that the cerebellar vessels on their way around to the cerebellar hemispheres also feed the brainstem. So in a patient with cerebellar signs, you should also examine their cranial nerves, for example, in order to establish whether there is brainstem involvement. So that's all I've got to say about basal ganglia and cerebellar lesions. Thank you for listening.